Hi, my name is Peter, and this is In with Peter Chulu.
Bridget, thank you very much for joining us this morning. Before we start, Bridget, could you just give us a quick introduction of who you are, what you do, where you're located, so at least some of the viewers can get to know you?
Sure. My name is Dr. Bridget Malewezi. I'm a medical doctor and public health specialist by profession. I'm currently the Vice President of Women in Global Health Malawi chapter. I'm also the chairperson for the establishment of Women Doctors Association. I'm a co-founding member for the Society of Medical Doctors. I currently do public health, as I mentioned. I'm mainly focused on women's health. So as you can hear, a lot of the aspects of supporting women's leadership and role in health, but do a lot of work in public awareness as well as engaging with the sort of society and medical profession in sharing about information on health. Yeah.
Great. Thanks, Bridget, for that. Well, Bridget, the reason I wanted to talk to you today is because I get asked by a lot of clients about the public health sector in Malawi, amongst other countries in Africa.
Sure.
I just wanted to find out from your end, how is that set up in Malawi? What kind of structure is it? So at least we know on this side of the world how the medical care system is set up in Malawi.
Sure. And I think I forgot to mention that I'm based in Lilongwe, Malawi, which is our capital city. Our health sector, maybe just to provide a little bit of context, our population is about 19 million people in the country. And most of our population is rural. So 84% of our setup is a rural setup. 84% of our population is in the rural areas, and about 60% of our population is under the age of 15, so quite a young population as well. And in terms of the demographics, 50-50, well, leaning more towards women, 51% of our population is female. So that also helps you understand sort of the lay of the land before I get into how the structure is set up. And so the way I've said it, as you can see, with a very rural population, when we're looking at the structure for the health sector, we start from the community, the villages. In the village themselves, there's often like community structures, mainly like village health committees. Some have like village clinics where community health workers might provide some care in the village itself. And some other like sanitation and hygiene aspects that are dealt with at the community level. So in the villages where people live, there is that setup of like some health interventions being done, sharing nets and other aspects. Then when you move from the village or the community where people live, the first sort of actual infrastructure you will have as a health center or a health post. So usually these will have a reach of 100 to 1,000 people. So we've got all of those around the country, spread around the country. And then from that level, if someone is dealt with, they usually deal with a minor, sort of a basic malaria case, something with minor conditions. Once you get that case and you're seeing that maybe it's a bit more complicated, they're referred up to what are known as district hospitals or the secondary level. And district hospitals, so each district, we have 29 health districts. Officially in Malawi, we have 28 districts, but one of the districts in Zimba is split into two. So in health, we have 29 health districts. And so most of the districts will have their own district hospital. And so most of these will have at least a number of they'll have a doctor, a number of doctors, but a lot of like other clinical officers and other cadres managing the cases at that center. And if for any reason, for like example, a case is more complicated and cannot be dealt with at the district level, then they're referred up to what are known as the tertiary institutions. We have 4 across the country, 1 in the north, Mzuzu, 1 in the central here in Lilongwe, Kamuzu Central Hospital, and then 2 in the south, Zomba and Queens. So those are the sort of major specialist hospitals where the majority of like specialized care would be dealt with in the country. So that's the structure overall. And the majority of our service provision is done in the public health, in the sort of by government. Most of these are Ministry of Health facilities or local government facilities. About 65% of our healthcare is given by the government, and then about 30% by mission hospitals under an umbrella known as CHAM. And then we've got a very small private sector, about 3-4%. So a lot of the bulk of the care in the country is being given under the government and by CHAM. Yeah.
Great, thanks for that, Bridget. I just was writing it down there. So just to summarize, you've got your village community setups, and then that goes into health center or health posts, was it? So
yeah, both of it could be that level, yeah.
And then it goes to district hospitals, which you said there's about 29 of them, roughly.
Well, some districts don't have like Blantyre, but yes, roughly, 27, yeah.
And then lastly is the tertiary institutions, right?
Yes.
Okay, so just to talk about a patient pathway. So let's say, for example, as you said, most of Malawi is based and situated in the rural areas, right? So let's say I've got a heart condition. I know that I'm meant to, the end game of it is that I need to be seen by the cardiologist, but I don't know that yet, right? So I'm in a rural situation. I've realized maybe I've got a bit of a pain in my chest or in my heart or in my cardiac area, somewhere there. So I take myself to, let's say, the village setup. Who am I being seen at that stage? Is it a GP? Is it a village doctor? Who am I seeing?
So at the community level, like cardiac conditions wouldn't be dealt with. So the first point of contact would, because at the community level, they're dealing with like minor fevers, malaria and things like that. So if you're a patient with like a cardiac condition, you would likely first be seen at the health center, for example. And at the health center level, it's usually medical assistants. So these are trained with a certificate level. That's sort of a certificate level. That's usually the level of the clinical personnel that is dealing with you at the health center level. They might have what is known as a clinical officer, in the similarity with the US system, like a physician assistant. So that kind of level is similar to a clinical officer that we have. So at the health center level, very rarely would you ever find like a doctor per se. You will find these two cadres, clinical officers or a medical assistant. And depending, like, for example, you have a cardiac problem, maybe you've developed like swelling of the feet, so they'll be able to pick it up and say, this is something like a heart issue. They probably would not have like X-ray or ultrasound or anything at that level. So they would refer you to the district hospital. At the district hospital, like I said, you might have a medical doctor. You would have senior clinical officers at that level too. So once you're referred to the district hospital, they would review you. And if they see, because they would, at the district hospital, they would likely have some medications, whether it's like furosemide or something that they would be able to deal with the condition if it's basic enough. But if at that point they still deem that this condition is beyond what the basic sort of cardiac care medication available at the district level, then they would then refer, like, let's say you were in a district like Kasungu, which is in the central region, then by that time they would refer you down here to Lilongwe to bring you to a specialist. So you would be seen by a specialist, often either at the central level, or, and I do know this is one of the things that's to try and reduce the burden of people traveling down to the central hospitals. Some of the specialists travel to various districts. So there'll be like one clinic per month where a specialist visits the district hospital. So some of these patients might be pulled together. So like, let's say, Peter, you have a cardiac condition, they recognize it, they would book you into that clinic, and then the specialist would see you on that clinic day. So that's how, those are the two pathways you would be seen. Either you'd be referred to the central hospital, or the specialist on his specialist visit days would see you in your district. Yeah.
Two questions around that, Bridget. Firstly, is who's deciding what kind of medication I get for my illness? So if it's a cardiac condition, is it the doctor? Has he got free will to say, does he have a list of medicines that he needs to pick from? Or does he have free will to say, I'll prescribe this and you can go get it from anywhere you like?
Sure. So I think that we do have like basic clinical guidelines and prescriptive guidelines that would give you a sense of, let's say, for example, someone would present with congestive cardiac failure, which is a very specific condition. Let's say the clinician at the district hospital has assessed, has discussed with his team. Usually they will have like, sort of a ward round. They will have at least one or two medical people in the team, and they will they can either use the clinical guidelines that are available to determine what drugs they can give. And also most of these districts have now got a connection to the specialists themselves in terms of like, at that point, maybe I've got a case which is slightly more complicated than a typical CCF. So then they would, at that point, discuss with the specialist, and the specialist might also give guidance in terms of prescribing. At the district level, the clinical officers, any clinician will have the prescription mandate. So they will be able to prescribe whatever is deemed necessary. And even, for example, if the specialist gives that guidance, then as long as the drug is available in the pharmacy, either they'll get it in their local pharmacy or they can buy it. Like often most of the clients, especially for slightly complicated cases, might get a prescription to buy outside of the hospital setup.
Okay, my other question was, how am I paying for all this? So obviously rural areas, not really enough funding in that area, maybe even on the personal side. If I don't have enough money, am I expected to pay for that, or is it the government? Who pays for my medication?
So for the government hospitals, everything is free. So you will be seen from start to finish. Even if you needed surgery, if you need something else, you will get it for free. And so it's free to you as the client, but it's subsidized by the government in various ways. So in the government system, everything is free. And so it's paid for by the government on behalf of the patient. In the CHAM system, which is the other majority, around 30%, there is some sort of contribution. And, it's often the reality is no one is paying, like it's not similar to like the global level where people are paying like thousands of dollars, understandably, because we're a rural setup. So they are paying like a very subsidized level of payment in the CHAM as well as and in the government system, they don't pay anything. In private sector, obviously you're paying for it either out of pocket or using insurance if you have insurance available to you.
And that's the 3% you're talking about, yes?
Yeah, 3, 4, 5%. There's not much. There's like very few sort of major. I mean, there's not many big private sector sort of providers in country. So they only contribute a small percentage.
And is there some kind of insurance policy where people can pay towards a private insurance, and then that then is contributed towards a bigger fund that you can claim? Or
Yeah, I think that's where we're moving towards. I think one of the major the major moves that's happened this past year was the government itself to provide medical insurance to civil servants. So I think civil service, being the biggest employer in country, has now boosted and it's not all the civil servants, but a specific level. But I think the fact that the government is shifting towards the realization that people should not be paying out of pocket. One of the challenges we find in the hospitals is that there's rarely any drugs because the government is paying for so much of it. Sometimes the drugs are out of stock. So you even heard me say, if the drug is not available at the hospital, you have to pay for it yourself. So even though essentially services are free in the government system, people are paying a lot out of pocket. And if you're going to the private pharmacist to buy the same drug, it's going to cost you a lot. So the fact that we're shifting towards promoting medical insurance, that's something that's happening, and the government has taken on board that. A lot of employers might provide health insurance as their own, and there's a number of schemes that are available for people to utilize. It's not a very common thing. I think I would say that it's less than 10% of the population are in health insurance right now. So it's a very small proportion of people who have health insurance. So a lot of people, if they get like a catastrophic medical issue, they're probably going to end up paying out of pocket.
Well, Bridget, thank you very much for that. I think we've had a quick snippet view of how the public health sector is set up in Malawi. Obviously, there's so much more to explore and so much more to discover, and things that maybe you didn't have the chance to speak about. But I just want to thank you for giving us an overview of how you feel, in your opinion, the public sector as a professional, obviously in that setting in Malawi. So thank you very much for giving us your quick 2 minutes of explanation. And we hope that we can come back to more questions once we find out areas to explore.
Happy to do that. Okay, great. Thank you so much, Peter. All right.
Thanks, Bridget.